So you hear in the media stories of Ozempic babies, is the headline I've seen a lot, where women unexpectedly had their fertility restored as a result of weight loss and treating some of the underlying insulin resistance. And they may not have been using protection, for example.
Hello, everyone. This is Dr. Nita Lwanga. I have my friend Dr. Sarah Stombaugh here with us today. She graciously talked to us a couple of months ago about weight loss. Today, we're going to talk a little bit more about obesity medicine, obesity medication specifically. I'm sure you guys have been seeing all the commercials on TV and hearing all the news reports about the proliferation of medications to help us lose weight. Even I'm feeling a little bit confused because some of the new meds are coming out, and then the drug rep comes for this medication. They're telling me their medication is better. Another drug rep comes and they're like, there's no head-to-head studies to say that medication is better than that medication. So I'm sure you guys, if I'm confused, you guys are even just as confused as I am. And so Dr. Stombaugh is going to, graciously tell us a little bit more about these medications. But before we get started, I'm curious, Dr. Stombaugh, what is your favorite guilty pleasure food, the food that you go to when you want to treat yourself?
Oh my gosh. I think so. The food that I like, the traditional, anyway, if I'm on a road trip or something like that, or the food that I just love more than anything, I'm so embarrassed to say, is Oreos. I love Oreos. I don't think I could coexist in the same space with them without eating them. And so I have to be careful and manage that relationship, but that is my favorite guilty pleasure.
I definitely approve. For me, it's just the chocolate. I'm good. I'll cheat. So Oreos, yes, I'm game for that.
Love it.
Oh, next time we meet, I'll bring you a bag of Oreos.
Please don't.
Maybe one of those little individual
Like
packs.
yeah, that's the way to do it.
So, in terms of weight loss medications, for our audience who are not familiar with the medications, what are some of the most popular common weight loss medications that are trending or that your patients are asking you for right now?
Absolutely. So I think what we are hearing about the most recently, what everybody's most excited about, is this class of medications we call the GLP receptor agonist. And so you may recognize names like Ozempic, Wegovy. Those are both semaglutide products. Names like Zepbound and Mounjaro, those are tirzepatide products. And there are other medications that are FDA approved for the treatment of weight, ones that we consider first generation medications that were approved really about a decade or even more ago. But these newer medications, the GLP receptor agonists, have really been almost a paradigm shift in the way that we think about and treat obesity, because they really start to work on underlying causes. So they are cool. Everybody is talking about them for sure.
So for individuals a little bit more curious, how exactly do these medications work? How can they help us lose weight?
Absolutely. So a lot of times they're categorized in one category as the GLP receptor agonist, meaning that these medications are glucagon-like receptor, they target that receptor in the body. And we have that receptor primarily within our GI system, within our pancreas, within our liver, within our stomach. We also have those receptors in our brain. We also have those receptors in other places like our heart, for example. And so we see that these medications, in stimulating that receptor, is able to have this direct effect on some of the metabolic derangements that happen with obesity. So a lot of times when we think about obesity, there has been this sort of crisis of how we understand it. For so many years, obesity bias of people saying eat less and move more, a lot of shame around weight, for example. But what we know is that chronic excess obesity, that excess fat mass, is actually really challenging to treat. Adipose tissue or fat tissue is actually very metabolically active. Sometimes we think of fat as like a blob on our body, but the reality is those fat cells, those adipose cells, are metabolically active and contribute to things like insulin resistance, to leptin resistance. So insulin is our energy storage hormone. If we're having insulin resistance, our body is more likely to be in this sort of energy storage mode. If we have leptin resistance, what happens also with obesity, leptin is one of our main satiety hormones. It helps us to feel full at the end of a meal. And when we have leptin resistance, our body is sending signals saying, hey, you should be full, but we aren't able to properly recognize those. And so these medications, the GLP receptor works directly on things like the pancreas to increase insulin secretion, works in the brain in some of those satiety signaling pathways. that these underlying physiological hormonal changes that happen with obesity, we're able to really get in and treat them at the root cause, which is really profound.
Wow, that is fascinating. So, how would you say these medications differ from some of the more traditional or older generation medications in helping us lose weight?
Absolutely. So some of the older medications that are on the market, there's ones like phentermine, for example. Phentermine, we primarily think of as it's not actually technically a stimulant, but it has this appetite suppressant effect where we're going to feel less appetite. There are medications like Contrave. This is a combination of bupropion and naltrexone. The idea of that medication is that it's working on our craving pathways. Medications like Qsymia, which is phentermine and topiramate in combination, that is working on hunger and working to decrease hunger. And so while those sort of indirectly work on hunger or cravings or these things that we know can contribute to weight, the GLP medications are actually working directly in those pathways rather than some sort of indirect effect on our weight.
So, are you still using some of the older generation medications along with the newer generation medications, or have you completely thrown some of those medications out of the way and you're focusing more on the GLP-1 receptor agonists?
That's a great question. So, the GLP-1 receptor agonist really, because they support within the gastrointestinal system, within the brain, we see effects both on the way we digest foods, the way, our insulin levels after meals, for example, as well as that GLP receptor in the brain and that leptin signaling, the ghrelin signaling. We find that people are not having as much cravings for food. You hear people talk about food chatter or food noise. That gets really well turned down on these medications. So head to head, the GLP medications are more effective compared to some of the older medications. And a lot of people really like the way that they feel and they can work in these sort of different pathways. So I say that to say a lot of times those are going to be the first choice of medication, broadly speaking, but there may be other factors where we consider other medications. So interestingly, before these newest GLPs came out, these are once weekly injection medications. There was a GLP medication, it still is on the market, called Saxenda or liraglutide. This is an everyday injection, and actually has pretty decent effectiveness, not compared to some of the newer medications, but compared to some of the older medications like Contrave, like Qsymia, like phentermine, has similar or even slightly better effectiveness than those medications. So there was a really interesting study. It's been about a decade now. I think it was in 2015 that this study was done, although don't quote me. But they took all of the medications that they had at that time. So before any of these new ones were on the market, they took Saxenda, they took Contrave, they took the phentermine, they took the Qsymia medication, and they looked at why people were struggling with their weight. Were they finding that they had cravings for their food? Were they finding that they were inappropriately hungry? Were they not reaching satiety soon enough? And then based on the way that they were feeling, they paired those patients with a medication to help support them more directly in the area in which they were struggling. And the really interesting thing is that over that study period, which again, I don't have the exact numbers, but was probably about a week, people found that the average weight loss was 15% total body weight, which is actually really impressive when we compare that to all of these medications individually are between like 6 and 11%. And so when they were paired with the right person, it could really be effective medications. So when I think about how I'm practicing now, there are patients for whom maybe they don't have as significant of obesity. Maybe they're struggling with binge eating or really craving for foods, for example. Those are patients who may benefit from other medications or may do well with one of these other medications that's less potent, but it's exactly in line with what it is their body actually needs.
Wow, that is so fascinating. I think some of us have been hearing a little bit more about personalized medications or genomic medications. I think it's
Mhm.
so interesting to bring all these medications, including all the new GLP-1 agonists, and pair them with the right person just to see what the effects are. I think that is so fascinating. I'm hopeful somebody's working on that study right now.
Mhm. Yeah, that's a good question. There's so many ongoing studies in this space. I'm sure there may be something like that.
Nice. And in your experience among the GLP-1 agonists, do you find one or the others more efficacious?
So the medications may make sense for a person depending on their diagnosis. So whether it is someone who has type 2 diabetes, whether we are treating for obesity. And so coverage of medications may be dependent on those conditions, for example. But when we look at Zepbound, which is a tirzepatide product, compared to Wegovy, which is a semaglutide product, these medications that are both designed for the treatment of obesity, head to head, actually, those studies are just in the process of getting published. And so we do know that Zepbound head to head has more effectiveness compared to the Wegovy medications. So, on average, in the Zepbound trials, based on what has already been published, depending if someone's on the 5, 10, or 15 milligram dose, we can expect about 15, 20, or 21% total body weight loss compared to Wegovy on average at the top dose, which was the studied dose 2.4, people had about 15.6% total body weight loss on average. So head to head, Zepbound does appear to be a more potent medication, but the Wegovy medication it's great, right? It's been around a little bit longer compared to Zepbound. Before Zepbound came out, that was our best option that was available. And I had patients who, even with that medication, had significant 20, 30, one patient even like 40% total body weight loss. So just because the average, there are some people who have less weight loss, there's some people who have more, but the average is a little bit more effective.
Wow. 40% of body weight lost is incredible. Even 10%. I think for anybody who's struggling with their weight, to be able to have a medication to help you lose weight is incredible, but 40% is incredible. And for those of us who do not know the differences in between these medications, say Wegovy and Zepbound, is there any difference? Why would one be more effective than the other?
Yes, absolutely. And so it's interesting because a lot of times these are referred as one class of medications, right? This GLP receptor agonist. But the tirzepatide products, so Zepbound, Mounjaro, those medications are actually dual receptor agonists where they're targeting both the GLP receptor as well as a second receptor called GIP. Now, GIP has slightly different, and I describe it as almost a synergistic effect with GLP, works to help support the medication in a different way. There's signaling also in our muscle cells with that, and so can be very valuable. And because of that dual receptor agonist profile, is more effective compared to just the single receptor agonist.
Oh, wow, that is fascinating. And I heard, is there another new medication that has three different mechanisms of action? I haven't been keeping up with all of this, but
Yes.
is that true?
Yeah, the retatrutide or retatrutide, I don't know how they'll pronounce it. That medication is in some of the final stages of clinical trials right now. So it's not approved yet, but it is a triple receptor agonist working on GLP, GIP, and then glucagon receptor. And so some of the preliminary data was really impressive. I think 26% total body weight loss. And so really pretty profound weight loss that they were seeing in those early trials. And it'll be exciting. I think probably at least 2 years before we see that medication come to market, but it's coming down the pike eventually.
Wow. I think we're living in very exciting times. And it's so interesting. With my background is in exercise and health physiology. So to be honest, I tend to have mixed feelings. I'm so excited for the scientific part of my brain that hears all these mechanisms of action. So excited about these medications. But there's another part of me that is like, medications tend to have some challenges sometimes. And of course, I want to counsel people. You need to exercise. You need to make sure your diet is good. You need to sleep. Of course, that's not enough for everyone. So I found myself feeling a little bit torn and also being concerned about potential side effects. When patients ask me for these medications, I try to have a very frank conversation and try to talk about the side effects. I have my list of contraindications and side effects, but since I don't do this every day, I'm not board certified in obesity medicine. I'd love to hear what are your thoughts on some common side effects people should be aware of or people who should absolutely not take these medications?
Great question. So, side effects are common, but usually tolerable. So, in the studies, many people had side effects. When we look at side effects like nausea, for example, 70 to 80% reported some amount of nausea, but most people reported that as a mild symptom. And so, I think it is expected, and I often counsel my patients that they should expect some of these side effects. When we look at the way hunger feels in our body, nausea, the way that these medications slow down gastric movement, for example, sometimes foods will sit a little bit heavy in the stomach. And so certain foods may be more likely to create nausea. So I can often find with my patients that having good expectations about staying well hydrated, getting plenty of electrolytes, avoiding certain foods, like a lot of times fatty or greasy foods just sit super heavy in the stomach when you're on these medications, and reducing or making sure to be mindful of portion size of those can be helpful for reducing that nausea side effect. But nausea, very common. We are often will do things like electrolytes that can be supportive, citric, like lemon juice, for example, can be a really nice option. A little bit of ginger, things like vitamin B6. I find by and large, my patients are able to use supportive care to reduce their nausea, making sure that they are eating, even if it's just having a protein shake or some bone broth or something like that, if they are feeling like really pretty significant appetite suppression. So, nausea, very common, but can be managed. We do rarely write prescriptions for medications like Zofran, ondansetron, in order to support people who are having more significant nausea, but that's really less than 10% of my patients would take a medication or feel like they even want or need to take a medication like that. Then lower GI side effects can be common as well. This most commonly looks like constipation, but can also look like diarrhea. Interestingly, diarrhea and constipation can be two sides of the same coin. And so those are very common. We often start patients as a prophylactic measure on fiber supplementation in order to reduce their risk of either of those two things. The most important thing with fiber is that you are getting plenty of water to reduce the risk of bulking up and creating a worse issue. But fiber can be a nice tool for reducing both constipation as well as diarrhea. We do occasionally have patients, maybe not, I'd say probably a quarter of our patients need to take a laxative medication when they are taking some of these medications, maybe not as an everyday thing, but just being mindful that they may be likely to have constipation. So that's something we're mindful of, making sure to counsel people of. And then we like to get ahead of constipation can be a pretty miserable side effect to have in one's life. And so getting ahead of that is really important. So those are definitely the most common side effects that we see. If you Google it, you'll find a couple percent of people had that, a couple percent of people had this. The lower GI side effects, or GI in general, upper GI and lower GI tend to be the most common. People do often describe feeling really cold on these medications, especially during these winter months. You've got the combined effect of losing fat mass, so you simply have less insulation, but there's also a metabolic effect of if you're eating less food, our body's burning less fuel, so we do get more cold easily. So especially in these cold winter months, lots of bundling up that I'm recommending to my patients. But most of the other side effects are mild and more rare. Now, in terms of patients who should not take these medications, absolute contraindications to the medications are pregnant women. So, a woman who is pregnant, planning to become pregnant within the next month or two, we do know that so many issues with fertility, like polycystic ovarian syndrome, for example, can create infertility issues. And so these medications actually help to work on the root cause of that. So you hear in the media stories of Ozempic babies, is the headline I've seen a lot, where women have unexpectedly had their fertility restored as a result of weight loss and treating some of the underlying insulin resistance. And they may not have been using protection, for example. And so they're more likely to get pregnant. Even with traditional oral birth control pills, the slowing of movement through the gastrointestinal system, we have to be careful that our body may not be appropriately absorbing oral contraceptive pills, so they're not able to be as effective. So typically contraceptive methods like IUDs, implants, or even a vaginal insert, for example, are a great option because those are not relying on taking a pill, swallowing it, and absorption for the metabolism and effectiveness of those medications. So we do not recommend it in that group. It's also not recommended in the breastfeeding population. While it does not appear that this medication can transfer in breast milk, it certainly can impair, and hunger could impair breast milk production, so it's not recommended in breastfeeding. It's also not recommended in patients who have a history of pancreatitis, and so it should not be used in that population, as well as patients who have a history of medullary thyroid cancer or MEN2 syndrome, which is a genetic cancer syndrome. Now, these are both really rare, and a situation that I run into very commonly is that a patient had some sort of thyroid cancer. Kind of depends on the sample size that you look at, but when you look at how many thyroid cancers are medullary, it's low. It's 2 to 3% of all cancers are medullary thyroid cancers. MEN2 syndrome, we're usually more aware that's happening because it's like everybody in the family is having some type of cancer crop up. And once someone's been identified, usually the whole family is tested. And so I do actually have a patient who's like half of her family has MEN2 syndrome, and she has been genetically tested for it and knows that she does not. And she's taking these medications, and we feel good about that. But medullary thyroid cancer is extraordinarily rare. And so we will often still proceed with a risk versus benefits conversation. Obviously, ideally, we'd like to know what type of cancer they had. Because of the slowing down of food through the GI system, that increased like slower gastric transit time and colon transit time, we do see that some patients, like if they had a history of gastroparesis, for example, where their stomach was not properly processing food or moving it through, those would be patients for whom we would be concerned about using these medications and would generally not recommend them. Um, but I think I got them all there.
Wow, this is so fascinating. And I want to go back to something you said about the tips you give your patients when they're losing weight and feeling cold to bundle up. I love
Mhm.
that tip. I think I'm going to have to start using it because our winter
Yeah.
is extremely cold. So that I really love that tip. And thank you for also pointing out that people should get genetic testing if there's a concern about some like MEN syndrome. I think that's really
Mhm.
important. And I think that's extremely relevant to point that out because, it is a serious condition, but it's fairly rare. So I think that's extremely important. And I love everything you said about women who are planning to be pregnant and breastfeeding. There's so many new medications. And at this point in civilization, we're not doing testing on pregnant women or women that are breastfeeding
Mhm.
with a lot of these new medications. Is not ethical. So I think that is a big challenge. That's a big challenge in population. So I think that's extremely relevant. And these Ozempic babies, I'm going to have to look up those articles because that's
Mhm.
fascinating. Yes, another thing I've been hearing on the news that I want to ask you about is Ozempic face. We were at the beginning of the show. We are just talking about your interview with Dr. Brenda Dinteman, who's a dermatologist. And I think for our viewers who are interested, you're going to have to go to Dr. Stombaugh's podcast listing and check out that episode on how to maintain your hair, your skin, and your nails while you're losing weight. But from your point of view, or even what you talked to Dr. Dinteman about. For people who are on Ozempic and they're looking good, they've lost weight, but now suddenly their face is looking really slim or they feel like they're aging, what are some things that they could do or should consider in that situation?
Absolutely. Thank you for the shout out. I as have a weekly podcast, Conquer Your Weight, and I would love for anyone to come take a listen. And we'd like to tackle lots of different weight related topics. And this one has been very prevalent in the media. We hear about Ozempic face, but it's really the issue of skin laxity in general after weight loss. And we know that in losing weight, it's common to have skin laxity. As we get older, it's common to have skin laxity. So meaning that our skin may sag, our skin doesn't have that same turgor. If you pinch it, it feels maybe more dry or more thin compared to when you're younger. It's got this sort of supple fullness to it. And so, both as we age, when we lose weight, these things contribute to skin that is a little bit looser. So, one of the things I would actually say is preemptively, if you're pursuing a weight loss journey, whether it is with the GLP medications, whether it's bariatric surgery, or whether it's a non medicated or non surgical journey, making sure that your rate of weight loss is not too extreme is really important. We know that as we're losing weight, we are likely to lose both some muscle mass. So, in the weight loss journey, it makes sense that we would want that to be the case where we're losing fat, but we really need to make sure that we're emphasizing things like protein in the diet, like resistance training. That's going to do its best to support your muscle mass. So we do sometimes see muscle wasting throughout the body, including on the face. But in our face, we often have fat that helps to keep that robust skin youthfulness. And it's very common in a weight loss journey that someone may be told, like, oh, their face looks a lot thinner, or they might notice that they're having some sagging skin. So, being intentional about the rate of weight loss, that you're not sprinting there as quickly as possible, trying to lose as much weight as possible, making sure to do things like having protein, having that muscle training, that can be important for supporting muscle mass. We do know that what our diet looks like makes a really big deal. So, looking at things like protein supplements like collagen, for example, may be beneficial in our hair and our nails and maintaining those, and then that not rushing it. There are cosmetic procedures, things like fillers, for example, things like microneedling. I think Dr. Dinteman and I talked about in terms of stimulating collagen production in the skin. But whether we're talking about face or whether we're talking about anywhere else in the body, we really want to be making sure we're getting all of our micronutrients. So recommend a good multivitamin, getting in that protein, getting in some collagen, not rushing through weight loss as quickly as possible, and then avoiding other things that tend to age the skin. So things like smoking, things like excess sun exposure, all of those can make a difference as well. Getting good sunscreen, avoiding smoke or outdoor pollutants can be really important.
Oh, that is awesome. And definitely the sunscreen, even in wintertime. I think Dr. Dittenman was on when we interviewed together with her, she was saying sunscreen all year round. So I think that is extremely important. And you also touched on something that we haven't really talked about, which is bariatric surgery. And I think our time is coming to almost to a close. So
Mhm.
one of these days, I'm going to have you back to talk about bariatric surgery,
Sure.
because that's something that has crossed my radar peripherally, but not very much. We do have a bariatric clinic in my province, or at least the city that I work in, and I realized I have not been sending a lot of patients there just because it's not something I think about every day. But from you, bariatric surgery, who's a candidate? Should we be using GLP-1 agonists with bariatric surgery? I have too many questions, but before I even go off on a complete tangent, another common question patients ask me when we're talking about starting GLP-1 agonists is what's going to happen if they stop taking the medication? We, in our system, even though it's government-funded healthcare, at this point in time, patients do have to pay if they do not have diabetes for the GLP-1 agonist, because it's, even though it's medically indicated, there's still for some individuals some like cosmetic component to it. We'll see,
Yeah.
maybe things will change in the future. But patients worry about affordability.
Mhm.
Some patients say, okay, maybe I'll take this for 3 months, but they want to make sure that the time and the money that they invest in this medication is not wasted. So in your experience, what happens when patients stop taking these medications?
Yes, absolutely. So, generally, I think it's important to note that these medications are designed for long term use. And so, one of the things that we're seeing right now, especially in the social media space, is that there are a lot of people talking about these medications as a short term, like jumpstart your weight loss goals or that type of thing. And these medications are both safe from a long term use perspective, as well as really designed to be used in that way. And if you think about other medical conditions like high blood pressure, hypertension, for example, when we're looking at treating someone with hypertension, we're thinking about multiple things, maybe medications, but then also the lifestyle piece. And those two things together, maybe we're increasing whole foods and managing the sodium intake and getting plenty of movement while combining that with a medication to support their blood pressure goals. And that person may achieve their blood pressure goals. And then when that happens, we don't say, okay, just stop your blood pressure medication. Now your blood pressure is being cured. It's not a cure for high blood pressure. It is a treatment for high blood pressure. And so I look at medications for the treatment of obesity and the exact same thing. They are not a cure for obesity. They are a treatment for obesity. And so all of these medications, they start at low doses and there's this sort of titration up that can or should do depending on a person's response, but you start at the introductory dose, and then depending on the responsiveness and side effects, how it's working, the numbers we're seeing on the scale, resolution of other health conditions, we move up to the next step. And then every 4 weeks at a minimum, we could move up if we needed to. And so what I find with some patients is that they move up and then they may at some intermediate, or even if it is at the top dose, reach their goals. Maybe they're reaching other health goals like coming off of blood pressure medication, seeing blood sugar improve, that type of thing. And then sometimes we need to take a step back. And so instead of stopping the medication, we may say, okay, instead of taking this high dose, you take the next dose down from that, for example. And when you're taking that dose, how is your body feeling? How is your body responding? And then from there, do we continue at that, or maybe we take a step back further? All of these medications are designed to be taken every 7 days. There's no formal literature on doing at different intervals, but you'll hear a lot of people talking about taking it every 10 days or every 14 days as part of that potential wean. But I would encourage people, occasionally there's reasons, whether it's a side effect, getting pregnant, coverage and availability of these medications, that a medication may be stopped abruptly. But the reality is, we certainly should not stop these medications abruptly. There may be patients for whom we titrate up and then start to titrate down partially according to how they're doing. But I certainly wouldn't stop them cold turkey. And most people find that being on a low dose of the medication long term is pretty in line with their goals.
Oh, wow. That is fascinating. I never even thought about titrating down to a lower dose if somebody, say, has reached their goal or feel like they've lost too much weight. But that is so fascinating. And I still have a million and one more questions for you. So I definitely have to have you back. But in order to be respectful of your time, I just want to say thank you so much for agreeing to be on our show again. answering all of our questions and sharing all of your knowledge. You have such a wealth of knowledge, and I'm just like so impressed. And just, I don't know what the perfect word is, but I feel like I'm listening to a lecture. Like I'm just enjoying myself because
Oh, thank you.
Yeah, you're like so fluent in everything that you say. I'm throwing curveballs, like different questions, and like you have such an insightful answer. So I'm really enjoying talking to you. I'm gonna have to sit down and binge your podcast and tell my patients who want to start these medications to go listen to your podcast and get more information. But thank you so much.
This has really been fun to have me on. Bring me back another time. We'll talk bariatric surgery or anything in the obesity space. I'd love to support you and your patients with that.
Absolutely. So everyone, please go and listen to Dr. Stombaugh's podcast. We're going to make sure that we put the link to her podcast below. For my audience or my friends who are in the US, Dr. Stombaugh, as far as I can recall, takes care of patients in Virginia, Tennessee, and Illinois. Is that accurate?
That is right.
Okay, awesome. So if you want somebody to help you achieve your weight loss goals and you live in one of these states, please feel free to reach out to Dr. Stombaugh. We'll make sure that we also have a link to her website as well so that you can reach out to her. Thank you guys for listening. Bye-bye for now.